and talking about a core essential in insulin. So this morning, I have the honor of presenting our first panel of the conference, What Insulin Started, CalRx, Public Pharma, and New Vision for Essential Medicines. Our amazing panelists consist of Allison Hart, Dr. Kate Topolis, Sarah Turner, and Chris Noble. This panel will be moderated by our very own Justin Mendoza. So I will hand it over to Justin to further introduce our panelists. Thank you.
Excellent. So I'm so thrilled to have this group, and we have another wireless mic that I'll grab in just a moment. But I'm going to start by introducing, actually, you're sitting in the order of the document. How did you do this? Okay, so we'll do this way. So we'll start by introducing Allison Hart, who is at the far end in the red here. Allison is the Community Development Director at T1 International, which is a long-standing partner of UAEM. It's an independent, global, patient-led diabetes advocacy organization that's been fighting for global health equity, active in the movement for publicly produced insulin since 2019. Allison leads T1I's campaign to expand public pharma initiatives in the U.S. She currently serves on the CalRx Insulin Patient Advisory Council in California and served on the commission to assess the feasibility and production of insulin in Maine and has supported the Insulin for All chapters across the US. She's an advocate for accessible essential medicines and who is inspired by her partner, Matthew, who has lived with type 1 diabetes for 40 years. Allison, welcome. To Allison's left, your right, Katie. Not Katie. I just said Nai there. I'm so sorry, Kate. Kate Topolis, MD, family medicine physician with the Royal Comprehensive Health Center, diabetes lead on ambulatory care for the Ambulatory Care Network. Kate is a primary care physician and certified diabetes care and education specialist, currently based at the Roybal, not Royal, that's me not reading, Roybal Comprehensive Health Center. Dr. Topolis was diagnosed with type 1 during residency, a diagnosis that changed the trajectory of her career and deepened her understanding of the hardships of a life with diabetes. She serves currently as the diabetes lead for the Ambulatory Care Network of LA County's Department of Health Services and is diabetes measure lead for the county's quality improvement program. And she's spearheading efforts to increase access to new medications and technologies and safety net systems here. She's also on the Patient Advisory Council for CalRx. And then I'm actually going to skip Sarah and introduce Chris because you've heard CalRx come up multiple times. I think that's a great way to close out introductions. Chris, who's right here, longtime UAM alumnus, but an organizing director with Health Access, where he's been organizing and building power since 2021. He has 10 plus years of community organizing and health justice advocacy experience. He's formerly trained under Marshall Gans at Harvard Kennedy School and then studied health system strengthening and prescription drug policy in a master's in public health program at the Boston University. That's when we met, way back in the day. So been making trouble ever since. In his bio, Chris says he's called to health justice advocacy from a personal diagnosis of insulin-dependent diabetes and understanding firsthand the importance of fighting for healthcare as a human right guaranteed to all. And then finally, last but not least, Sarah Turner. Sarah Turner is here as the pharmaceutical project manager at the California Department of Health, Care, Access, and Information. She leads the CalRx insulin and albuterol initiatives and supports the research of future target drug opportunities for CalRx. Sarah has 18 years of experience in state government and is skilled in healthcare project management, as well as, I just lost my own train of thought. Very great. Okay, great. Program design and technical writing. She's previously held positions at the California Department of Public Health, the Commission on Behavioral Health, Department of State Hospitals, and the California State Prison in Los Angeles County. She's passionate about uplifting the consumer voice in her work to improve medication access and affordability for all. Awesome. So this is a fantastic expert set of panelists, and I hope that as we dive in, you're going to be able to take away some amazing lessons. So first off, we're going to pass well, I'll pass my mic and I'll grab the other one. We're going to start with Allison to introduce us into the topic and get us going.
Okay, awesome. Great to be here with you all today. As Justin mentioned, we've been a longtime partner with UAM, and it's just an honor to be here. So before I dive in to a little bit more detail, I just wanted to start off with anchoring like why I am in this work, because if you're going to stay in this work, you're going to need a good reason. It can be tough, but it's so, so essential. So I just want to share a little bit of my personal story, my family's personal story, which is that my partner, as Justin mentioned, Matthew, has had type 1 since he was 7. And almost 10 years ago, he got the flu, and he ran through his insulin faster than he usually would. So he was completely out. He went to the pharmacy 2 days early to pick up his prescription, and insurance wouldn't cover it yet because it wasn't the 30 days. The out-of-pocket cost at that time was going to be $1,500 for his box of 5 pens. With insurance, it should have been $82 at that time. And there wasn't a generic or low-cost alternative available. It was a Friday, and he couldn't get a hold of his doctor, and he couldn't get any help from the pharmacist. They didn't have any solutions. So, their solution was pay $1,500 for the list price. And you can't wait for 2 days to get your insulin when you have type 1 diabetes. And so he went on Craigslist and he found a stranger who was selling their insulin. It was actually their uncles that had switched formulas and didn't need the one that they had anymore. And he went to a gas station parking lot, a Wawa for any East Coasters. Look at that. And got his insulin for $20 from this person and hoped for the best. And our story is unfortunately not unique at all. And so that really, especially in the type 1 diabetes community, and neither are the feelings of fear and frustration and just like personal failure that kind of come with that experience. So being in this room with the fact that we're here for this conference, I'm assuming that a lot of you have a sense and agreement, maybe that there are some serious problems with how our access to essential medicines work, especially in the United States. And so I am really excited to be able to talk about some concrete and tangible ways that we are making sure this does not have to be our reality. So we're going to talk a little bit about insulin, which became the poster child. Oh, you know what? I'm not doing a good job of this. Maybe I'll just say slide because I kind of forgot it was supposed to be. There we go. That's a box of pens for reference. So this is what costs $1,500. Great. So here we are. So insulin became the poster child for the problem with high drug prices in the United States because it is such a glaring example of what is flawed in the system. It's really dominated by pharmaceutical greed and market concentration. So insulin is, over 100 years old, and the discoverer Frederick Banting famously said, "Insulin does not belong to me, it belongs to the world," and then sold his patent for $1. That is the patent. And then if we fast forward about 100 years, we've come a long way from Banting's dream. The big three, Eli Lilly, Novo Nordisk, and Sanofi, have a monopolistic control of the insulin market, over 90%. And since the 1990s, the cost of insulin increased over 1,200%, with the big three charging around $300 for a single vial, even though the cost of producing that vial is about $3 to $6. So you can see the inflation there. And enter T1 International, which, as Justin mentioned, is the organization that I work with. We are a nonprofit led by people who are impacted by diabetes, for people with diabetes, fighting for global healthcare equity. And we're really unique in the healthcare advocacy space because we don't take any funding from the pharmaceutical industry, which might seem like an obvious move, but it is extremely rare. So we've been building momentum for the public pharma campaign since 2018, driven by our community, because it was really clear that the private profit-driven companies were not working for those most impacted. We've seen people rationing their insulin, and even we have several folks in our community who have lost loved ones due to lack of access and affordability of this basic medication. So every 2 years, we run our out-of-pocket expenses and rationing survey. It's the only data collection of its kind, and that it's fully patient-led. And in 2024, it showed, once again, over 1/3 of people, 37% of people with type 1 diabetes rationed their insulin within the last year. And it also showed clearly that this challenge is not limited to insulin only, but also the glucose self-monitoring devices that make it possible for someone who's living with insulin-dependent diabetes to know how much insulin to take and keep their sugars in control. So we know there's a problem, and as this slide shows, the pharmaceutical supply chain is extremely complicated. When we at TU International are talking about public pharma, we mean governments being held accountable to their citizens in a commitment to make essential medicines a public good and taking action to provide a balance to the private players in our system at any point in this chain, really. At TU&I, we focus our advocacy on policies that allow governments to create competition or leverage a balance to the private companies in the form of either bulk purchasing by taking on some of the PBM or pharmacy benefit manager functions, or manufacturing and own supplies of essential medicines. And ultimately, our goal is that people will be able to walk into their pharmacy and pay a promised price without hoops, coupons, additional barriers, just a transparent, stable, and affordable cost to the patient at the point of sale. And what we learned in this work over the last 8 years is that we really have to be thinking about these multiple points of intervention. In our US systems, that means considering insurance plan adoption, distribution, pharmacy stocking, and familiarity of patients themselves so that they're aware of their options, because we need to have more competition in the market, but we also have to be able to ensure that people can access the alternatives that we're creating. And so this thinking of the supply chain holistically is more critical now really than ever. In recent years, we've seen many drugs go through shortages. For insulin specifically, we've had shortages and discontinuations around the globe. So with the promise of GLP-1 profits, which are led by Novo Nordisk and Eli Lilly, makers of the blockbuster GLP-1s, Wegovy and Ozempic, we've seen them pivot their capacity. And it's important to know that the same delivery device, the pen delivery device that delivers insulin, is what delivers many GLP-1s. So in March 2023, Novo Nordisk announced that it would be lowering the price of its insulin Levemir in the United States by 65%, to which they got lots of accolades in the press. But just a few months later, they then quietly said they would instead be discontinuing it and pulling it from the market completely within the year. So that is an insulin that is one of the most commonly recommended for people who are pregnant. We've also seen in 2024, Novo pulled their human insulin pens entirely from the market in South Africa with very little notice, which forced patients back onto vials and syringes as their method without very much warning. And this came despite clear evidence in a survey that we conducted in partnership with Doctors Without Borders that revealed an overwhelming 82% of individuals with diabetes favor insulin pens as their device to deliver their medication. MSF led an action, which this is our, in the lower corner, Janice, our South Africa chapter leader, participating in that action. And now, just a month ago, or just this month rather, or rather end of last month, Eli Lilly announced that they are scaling back their insulin footprint in Europe with plans to discontinue a swath of products for quote unquote commercial reasons as they have their GLP-1 manufacturing capacity. So the good news is that the global movement for public pharma is growing. We have Insulin for All chapters and advocates, as well as global advocacy partners who are working with their governments where localized production for manufacturing facilities that will handle both API and fill and finish, as well as tech transfer, are moving forward in Pakistan, in Nigeria, and in Brazil, which you'll see some of those. And here in California, as we're here to talk more about today, we have this exemplar in the United States of CalRx, which has already inspired state-level action in other states like Maine, Michigan, Oklahoma, Connecticut, Ohio, Vermont, and New York, and more to introduce public pharma policies of their own. At T1 International, we've just recently also launched our Global Public Pharma Working Group so that we can share lessons across borders. So we are growing this movement for rethinking our drug supply chain. And while insulin has been a catalyst, the policies apply to many essential medicines. Governments can make this promise to their citizens to treat these essential medicines as public goods. We can have this world where patients have the access they need and where a prescription running out doesn't mean that you have fear or frustration or feel like a failure. What's happening in California right now is exciting, and it's the result of years of tireless advocacy and a belief that we can do this. So if you're interested in diving deeper, I hope that you'll check us out. We have the Get Involved will take you to our newsletter because later this year we're going to be running a public pharma mobilization, educating and taking action on public pharmacy with our chapters around the globe. We also, if you're interested in diving deeper on the policy side of it, we published 2 policy toolkits on public pharma policy approaches with our partners at the NYU Science, Health, and Information Clinic. And those are on our website, /public pharma. And of course, reach out if you want to connect. And I'll pass it to Sarah.
Awesome. Thank you so much, Allison. All right. And next up, we're actually going to pass it to Sarah to talk to us about CalRx and dive us into it. Go ahead.
Thank you so much. It's so wonderful to be with you all today, and I'm honored to share the floor with our CalRx Patient Advisory Council members. That was a great introduction to the problem, Allison, and thank you for sharing your personal story with your partner. So I'll be sharing more with you about what is CalRx. Slides going. So CalRx is a state-powered pharmaceutical market disruptor. We aim to make medication more affordable and accessible in California. And we were launched as a state-led initiative by Governor Newsom in 2019 and formally established in 2020 through legislation known as the Drug Affordability Act, or Senate Bill 852. Which empowers the state to enter into partnerships to develop and distribute low-cost generic drugs that result in a cost savings for consumers. Our vision is an equitable, transparently priced pharmaceutical market where all Californians can afford and access the medications they need for healthy lives. And we target areas where the U.S. healthcare system has systemically failed to lower drug costs, even when a generic or biosimilar is available. And all CalRx pricing is based on the actual development, production, and distribution cost of the drug with no markups or rebates. And our program is housed within the California Department of Healthcare Access and Information, where I work. And I'll transition us. So how does CalRx work? To date, we have utilized 3 different models for intervention in the pharmaceutical market. First is our direct investment into the development of biosimilar insulins, which I'll dive deeper into in a moment. Second, also in the same year that we announced our insulin initiative in 2023, we undertook a short-term stockpiling effort of a reproductive health drug, misoprostol, in response to U.S. Supreme Court actions at that time to ensure stable supply in the state. And then our CalRx naloxone access initiative was announced the following year in 2024, which is a partnership with a U.S.-based pharmaceutical company, Amneal, who manufactures our CalRx branded or private label generic over-the-counter naloxone nasal spray at a reduced price. And this is a life-saving drug that can reverse an opioid overdose. We're proud to share since May 2024, our partnership with Amneal has been the primary supplier for the state's naloxone distribution project, which is operated by the California Department of Healthcare Services and they distribute naloxone for free to qualifying community organizations such as harm reduction groups. And just last year in April 2025, we launched our first CalRx direct-to-consumer mail order solution. So any Californian can now buy CalRx naloxone at the same reduced price, which is now just $19 per twin pack. And you can find out more by visiting calrxnaloxone.com for that product. So moving specifically into our insulin initiative, this was announced in March 2023 with our partnership with a nonprofit manufacturer, Civica, to develop 3 biosimilar versions of the most widely used insulins, which are Glargine, Aspart, and Lispro. Our agreement includes $50 million in milestone payments to support the development and manufacturing at Civica's facility in Petersburg, Virginia, and commercialization efforts at retail and mail order pharmacies. A key requirement of this partnership is affordability. That CalRx branded insulin will be offered at no more than $30 per vial or $55 per pack of 5 pens as a maximum retail price, which set a new benchmark for insulin pricing. So where are we now with CalRx insulin? While Civica has made very meaningful progress in developing our biosimilar insulin Glargine products, it is a complex effort due to the rigorous manufacturing, testing, and quality requirements involved. So to ensure timely access while that drug development effort continues, Civica partnered with Biocon, another manufacturer already on the market, to launch an insulin Glargine pen under the CalRx label in California and the Civica label nationwide, which began this January 1st, 2026, again at the same promised price of $55 per 5 pack. And this product is interchangeable with the brand name Lantus and can be substituted at the counter without requiring a new prescription. And broad wholesale distribution allows any pharmacy in California right now to order this product. And to wrap up where we're at with insulin and really the impetus of why we're all here on the floor today, very happy to share in 2025, we launched our CalRx Insulin Patient Advisory Council as a platform for CalRx and Civica to receive ongoing patient feedback, which is informing our access and distribution strategies to make sure we're reaching all Californians. And again, I have the honor of facilitating that council, and my colleagues here with me today, Allison, Kate, and Chris, have been so instrumental in this work. And so what's next on the horizon for CalRx? I'm pleased to share that through a $5 million state budget reappropriation to address emerging pharmaceutical needs, we are partnering with the California Department of Public Health to launch the new CalRx School Albuterol Access Initiative. And the intent is to create a centralized ordering system and provide an emergency stock of albuterol inhalers and spacers to all of California's public and charter schools at no cost for 3 years, beginning this summer, 2026. And each participating school will receive a first fill of 2 inhalers and 25 single-use disposable spacers per year, with the option to purchase additional refills as authorized by the Department of Public Health's statewide standing order. And to support statewide delivery, we issued a state procurement document known as a Request for Information, or RFI, in the fall of 2025. And we are currently in process of identifying a partner to help us manage the manufacturing, ordering, and direct distribution to schools. And as part of that RFI, we did ask a question around potential broader market interest. to possibly provide a low-cost inhaler to all Californians at a later date as a future project phase. And that would be similar to our naloxone initiative under the CalRx label. And so I think this is my last slide. I just want to share more about what CalRx has in terms of goals for the next 6 months. Our primary goal is, again, to transform the pharmaceutical market by leveraging our state's market power, increasing market competition, and lowering costs. So we will continue exploring other target drugs we can intervene in and lower prices, with that being our primary focus, the yellow circle you see here for market intervention. But we do also aim to broaden our work beyond market intervention to prioritize policy research and data analysis, which is depicted here, the other two circles, to help with the overall improvement of medication access and affordability. So we know market intervention and policy solutions go hand in hand. Specifically, we want to help reshape pharmaceutical policy by identifying problems and recommending policies to our legislature that reform the pharmaceutical system and help shift us more towards increasing data and pricing transparency, because we know we still have a long way to go. And with that, similarly, I've provided our website for you all to find out more information about us at calrx.ca.gov. And you can also email our team directly through our website. Thank you again for your attention.
Thank you so much, Sarah. And just a momentary reflection on that, which is to think, I'm remembering the first time I sat in the seats here as a UAMer at a conference in 2010. Yes, I am old. But when sitting there, to hear an actual solution that's gone to the point where the market is being affected by advocates who are trying to change the way that medicines are affordable, that is huge. So very cool to hear this. Dr. Topoulos, I'm going to hand it over to you to talk to us about your experiences and bring us through.
Thank you so much. Hi, good morning, everyone. So excited to be here. I feel like this whole room takes me back to being in college, so I'm really excited to be here with you all. So as Justin mentioned, I'm Kate Topoulos. I'm a primary care physician. I work for the County of Los Angeles. I actually did not spend all of my training time in California. I'm from the East Coast and I did some training there. And I also have type 1 diabetes. So I just wanted to talk a little bit about my experience, both as a physician and a provider for people who have diabetes, but also as a patient myself, and kind of what the experience has been like, especially as it relates to insulin. So when I was in medical school, I was trying to think of what specialty I wanted to go into. And I was really invested in the patient experience and really connecting with my patients. So I knew immediately I wanted to go into primary care. And if you're not already aware, primary care and diabetes kind of go hand in hand. I would say that diabetes is kind of one of the bread and butter things that we do. So when I was an intern in residency in Philadelphia, I was starting to treat patients, feeling pretty confident, still kind of getting my legs under me. But I found that I had diabetes that year. I had a needle stick injury. I found out my A1C was 13.1. And in the middle of my training, I kind of had to change my whole life. And I started on insulin. And I learned very quickly that I not only didn't really know a lot about insulin, but I also really didn't know what it was like to have a chronic medical condition and kind of the real patient experience of that. And I was pretty embarrassed to learn that in real time because I had spent the better part of that year treating so many patients, giving them insulin kind of offhand, and not actually thinking about what that experience was like. If you're not aware, not to discourage anyone in this room who's thinking about going into medicine, but residency is basically a minimum wage position. And so when I first went to the pharmacy to pick up my insulin, I was pretty shocked at how expensive it was. I was on my employer's insurance. I went to the pharmacy and I could barely afford to pay for it. I later on started on an insulin pump, and I want to talk a little bit about a story that I had when I was moving to California. I started the drive to California. I had my dog in the front seat with me. My husband was starting his residency here, and I had my insulin in the back in a cooler. And for those of you who aren't aware, when you're on an insulin pump, like I was at the time,
it's always recommended that you have backup insulin pens, just in case something goes wrong with the pump. Because I was finishing my residency at that point and going into fellowship training, I could not afford to have backup insulin because you had to pay extra $300 out of pocket for that backup insulin. And at the time, between jobs, it was not something that really fit into my paycheck. So I was driving along with my insulin pump, and I had my separate little controller phone to control the pump, and it fell into the cooler and stopped working. I was in the middle of New Mexico, stranded. There were no pharmacies open. It was late at night. And I realized that I only had expired insulin to use. So I kind of just went with it and tried to use that overnight. I ended up calling a pharmacy in Albuquerque the next day as a prescribing doctor for myself and sent myself insulin, and I drove to the pharmacy. And I ended up paying the multiple hundreds of dollars out of pocket. But really what the pharmacist couldn't believe after they confirmed that I, as the patient, was also the prescribing physician, was I was also uninsured because I was between jobs and I couldn't afford to pay for the COBRA insurance. So multiple rounds of me really feeling so affected by the fact that I not only couldn't go more than 6 hours without this medication, but I, as a graduated MD, had already gotten through my residency, really couldn't afford to pay for the prescription. What that looks like for me now is actually a little bit different. So for those of you not aware, the County of Los Angeles primarily services Spanish-speaking patients, at least in the East LA clinic where I work, and almost everyone is on public insurance. What's interesting about that is that when you're on public insurance, cost is not necessarily the main issue that you face, because insulin is generally regarded as a covered medication. However, what that means for us in that system is that choice really becomes the problem. So as a physician, you're generally taught human physiology quite well. I know medications very well and how to prescribe them. You're not actually taught the real world experience of cost. So I know almost nothing about medication costs in terms of my actual medical training. And I think that's kind of a good thing, because if I knew what things cost, I would be less inclined to prescribe them for patients. But what that means is when you're a physician, you're shielded from the cost of things. It also allows the market to really take advantage of that. We prescribe what we think is best for our patients, but what that means is we're not taking into account the effect on the larger system. So right now, we talked a lot about this on the CalRx panel, but when you're faced with the choice and you end up changing your insulin type, a lot of times, as someone who can advocate for myself, I'm very fearful of that. I don't want to change the type of insulin I'm on. But my patients are generally not aware of and can't advocate for when the formulary just changes on them, because they are at the whim of their insurance, which is a public insurance. They're given a service, and if something changes, there's nothing that they can do to fight for that. So it's a very disconcerting process to be a part of, and I think that choice is a really big issue when you have diabetes, because this medication can save your life. It can also kill you if you use it the wrong way. And the fear that comes with having to change your medication all of a sudden without notice is really underestimated. And it's something that I lived personally. So I think in the hospital setting and in clinic settings, we really need to do a better job of educating physicians on cost, but coming up with a program that really intervenes to say PBMs don't have the primary, control over what things cost. There is a workaround for that, and there's actually some sort of market competition, is hugely important, because otherwise we just continue to let things climb, and then we lose access to the things that we need the most. So I'm so grateful for the work of the people on this panel around me, both as a patient and as a physician. And I definitely think that in the county system, especially where patients lack a lot of choice and a lot of their own autonomy over their medical care, it's hugely important. So I'm so grateful to be here.
Thank you for sharing your story and experience. It's eye-opening, right, to think about from both a physician and a patient perspective as well. So thank you. Chris, I'll pass it to you to round us out.
Great, thanks, Justin. Hi, everyone. My name is Chris Noble. I'm the organizing director with an organization based here in California called Health Access California. We've been around for over 35 years. We're mostly based in Sacramento. We're mostly focused on passing legislation helping to influence the state budget to get us towards a universal, equitable, and affordable healthcare system. So my role as an organizer is to find constituencies all across the state and try to organize them in a way that can pressure our legislators and our governor to enact the type of healthcare system that we want. So let me take a step back. I'm a former UAMer, as Justin mentioned. I always say I cut my teeth, a saying, meaning I sharpened my advocacy skills because of UAM. I was a chapter leader at Boston University School of Public Health, and I was also on this coordinating committee along with Justin, and helped plan the BUSPH conference back in 2014. So I know how much of a lift this is, and I'm so appreciative to this chapter and all of UAIM for, keeping the flame alive, keeping the movement growing. UAIM was foundational to my ability to really professionalize as an organizer and an advocate. So keep it going. But where does my advocacy come from? As Justin mentioned, I was diagnosed with type 1 diabetes back in 1995. Back then, you were put onto human insulin, which is an older form of insulin that worked pretty okay, but the lifestyle was, you had to kind of change your lifestyle to utilize the insulin, not really use the insulin to manage your lifestyle, meaning I had to eat at certain times, I had kind of a strict diet, and I had to exercise very intentionally to maintain those blood sugars throughout the day. It was a little more restrictive. Then in 1996, I believe, the new analog insulins came online, and those were much better controlled. So you take a shot in the morning, that lasts you 12 hours, and then you take an additional, what's called a fast-acting insulin shot anytime that you eat or if your blood sugar gets out of range. So a lot more conducive to a lifestyle that you would want to live. And since then, now we have amazing technology. I mean, it's truly revolutionary in the quality of life that people with diabetes can have compared to what we were seeing 100 years ago, where it was a guaranteed death sentence. I run triathlons. I'm a professional. I work pretty actively, travel all around California organizing people to make a better healthcare system and help improve their access to care. And I'm very lucky to be able to say that because, as I think Allison shared, 37% of people in the US still ration their insulin because of high costs. And I don't remember what the exact figures are now, but back when I was looking at it a couple of years ago, it was 1 in 2 people, or 50% globally, struggle with regular access to insulin. So it is still a death sentence for many. But to talk about the rosy side, I want to talk about just why this project, the CalRx Insulin Project in Public Manufacturing, is so, frankly, revolutionary. And I want to ground it in maybe some experiences that we talked about today on the panel. For people with diabetes, taking your insulin is not optional. You have to take it every single day. You have to titrate how much you're taking for how much food that you're eating and how much you exercise. It is a lifeline. It is not optional. If you ration for a series of hours, you can end up in the ER. So you need to have continuous, consistent, and confidence in the drug that you're taking, that it is consistent, and that you have regular access. I know right now that I have about 3 months worth of insulin in my fridge at home. The timer is always clicking for people that have diabetes. You need to know where your next insulin shot's going to come from. So imagine you're traveling, you're on a business trip. I went up to Sacramento right after I got the job at Health Access, and I was like, "Ooh, going to Sacramento, like big deal, the capital's here." And I brought a vial of insulin, as I do. I bring it everywhere that I go. It's my little buddy. And as I'm getting off the plane, someone bumps into me as I'm trying to kind of fumble with my insulin. It falls on the ground and the vial breaks. Imagine carrying around, and this is kind of hard for people without diabetes to understand. You're walking around with your lifeline, where this little vial of insulin costs $300, sometimes $400. So it's like a little vial of gold that keeps you alive every single day. If you drop that on the ground, your day is shot. Doesn't matter how important, doesn't matter if you're meeting with the governor in 5 minutes, doesn't matter if you're meeting with the attorney general, which we were later that day, to talk about an insulin lawsuit they were pursuing. You need to figure out how you're getting insulin. And so thankfully, I have health insurance. I was able to go to a pharmacy. They were able to fulfill my prescription. I still paid out of pocket, but it was okay. I was able to get it reimbursed through my insurance. The reason why this CalRx program, and by having specifically the piece around it being interchangeable with a current prescription is so important for people with chronic diseases is that suddenly every pharmacy has your medicine in it. And you can pay for it at a much more reasonable cost, which is much closer to the cost to manufacture that drug. So now, let's say I'm on that same plane right up to Sacramento and I drop my vial. Instead of having to worry, where am I going to scavenge up $400, you could walk into the pharmacy, show your active prescription, and get a purchase of 5 pens for $55. Much better. Suddenly, you know the saying, water, water everywhere, but not an ounce to drink. Well, suddenly you can drink the water that's around you. You can access the insulin that's nearby. And that is really revolutionary for people with chronic diseases. Now to put my like kind of policy nerd hat on, which I wear proudly. I, as Justin has as well, as many of you hopefully will, we've been very active in the kind of policy advocacy space to try to bring down prescription drug costs across the country. And the beautiful thing about the United States, which these days those are limited, but we do have 50 states that are basically policy incubators to try new ideas, to figure out how we can improve our healthcare system by innovating in different states, learning what other states are doing, and try to innovate off of those ideas. Prescription drugs is a very difficult space to advocate in because the industry is so powerful. They will just create a firewall against progress if you try to limit their ability directly to contain costs or, God forbid, put a price cap on their products. And we've encountered that. Many states have tried setting upper payment limits, launching pharmacy review boards, price review boards, which have passed and have made great progress. And it took very long, multi-year campaigns with hundreds of thousands of people trying to advocate and influence legislators to pass these priorities. If at any point you try to retain or contain costs in the pharmaceutical industry, pharma will organize against you. But what's beautiful about what California did back in 2018, 2019, is rather than taking on pharma directly and try to contain the costs of products that are already on the market, California said, what if we just made our own product? What if we just got around the pharmaceutical industry entirely? Insulin is a 100-year-old drug. The most recent versions that I said came out in 1996, those are off patent now. The patent has expired. The IP is accessible. And so the state very proactively, and I want to say because of advocacy of groups like Type 1 International, patient advocates for over 100 years now, but especially in the last 10 to 15, because of the price crisis that we've been encountering, have been raising the temperature on just how unacceptable it is, how high these medicines cost, just how expensive they are for people. And so it's because of that advocacy, because of that raised temperature that is brought about from consistent organizing and advocacy of patients and their allies and their comrades, that the temperature risen so much that insulin had to be reckoned with at the political level. So Governor Newsom came into office in 2018 and was looking at the landscape saying, whoa, this insulin issue needs to get reckoned with. What can we do about it? And then suddenly, you know, we're learning from what other states have been trying to implement. They're hitting firewall after firewall. Then California says, well, what if we just make our own insulin? We have 15, I think it's upwards of 17 million people on public programs now in California, Medicaid. That's a huge budget cost to the state to then have to pay for, let's say 10% of them are insulin independent. These are very round numbers, not precise. My apologies, panelists. But that's still 3 to 4 million people with diabetes that are on Medicaid. That is a huge public cost. So a one-time budget investment of $50 million to help start up a 10-year contract with CalRx, an existing biological manufacturer, that is then able to offer that product at near the cost to manufacture. I mean, Allison said it before, it costs $3 to $6 to make this vial of insulin. The big three charge it for $300 to $400. That's absurd. That is a crazy profit margin. If the state is selling it for $30, how much money is the state saving? So CalRx not only got around trying to regulate pharma, because you don't want to poke the bear, they will swipe back. We were able to pass this initiative because of the patient advocates that raised the temperature politically to make this something that our politicians had to reckon with and think innovatively around solutions. And now we have implementers like Sarah here who are now also thinking creatively of, well, what can we do to ensure that the drug is actually getting to the people that they need to? And that's what the Patient Advisory Council is really wrestling with now. California is a huge state. We have very rich parts of California and very poor parts of California. We're very urban dense parts of California and very rural parts of California. There's places in California where there's been self-prescribed insulin deserts or pharmacy deserts, where there's just not a lot of opportunities for people to access insulin on a regular basis. So something that we've been wrestling with on the Patient Advisory Council is how can we, in partnership with CalRx, think innovatively about how we can actually get these drugs to people. Insulin requires cold chain storage, so you can't just mail it in your normal mailbox. You're also, sending it on a regular basis, so you need to take into account whether someone has stable housing. And so what we're wrestling with now is how do you actually get the drugs to the people that need them in a regular and consistent fashion? And that's the type of like work that a public program I think is more invested in, because they actually want to see, they're not just about sale, I don't care how you get it, just buy it and figure it out. Like the state actually wants it to get to the people and help people stay healthy, because that also keeps them out of the emergency room. It's keeping people healthy so that they're not a further financial or health burden to themselves and to the state. So that's kind of what we're wrestling with on the Patient Advisory Council. There is also very valid concerns, I think, that Kate brought up around a new drug suddenly introduced to a person with diabetes can be disorienting. I actually just switched over to Biocon insulin through Kaiser, and I was like, oh, I've never used Christie insulin before. It's normally, I know Humalog, Novolog, I know the names of the big three, but suddenly I get a Christie insulin. I was like, who's Christie? I don't know Christie. Works great. I'm alive today. My blood sugar is awesome. So it's obviously working. But it takes, you need to have confidence that this new medication is safe and consistent and something that patients can trust. And so that's also something that we're kind of working with on the patient side. But all that to be said, keep organizing, raise the temperature on the issues that you care about. Because if you get enough people involved and you raise that temperature high enough, being organized and forcing the legislators and our representatives to reckon with that reality can enact change. And this is an example of doing so. So thanks for everything you do, and I'm happy to answer any questions.
So good. While you all were speaking and talking through what's happening in California, this just kept raising for me memories of earlier pushes to try to get the federal government to act on insulin, which still are continuing. They're still important to push, but I just wanted to point out the major difference here with what we're talking about in California is real, actual change. We're seeing that $55 5-pen pack. That's amazing. The other things that are coming down the future, that's fantastic. And real patient advisory, that's fantastic. What we've seen from raising the temperature in DC over years was coalitions of folks and organizations and think tanks and reports and lobbyists and all this work to only get the US government to commit to, in some cases, limiting the cost of insulin to $25 a month if you have the right type of coverage. So every time you hear a caveat in policy, you have to remember that that's millions of people that it doesn't apply to. So the cost of insulin being limited when that was so celebrated to $25 per month for some people, it was only seniors on Medicare at first, and then it was expanded voluntarily by insurance companies. And as we saw earlier, that only matters if the insulin exists or if the companies are even going to continue carrying forward with those plans. So it's truly innovative to see a different approach. But I want to ask a question that to kick us off in kind of a Q&A spot. But if I want to ask everyone here, if you're one person trying to wrap your head around what you can do to help push on this issue, to push on the idea of public manufacturing, what can I do? What can that one person do to get started?
I would say you're doing it because you're in this network already of people who are meeting and wanting to make change. And it's true that movements have ideally thousands of people that are raising the temperature, but the kind of reality on the ground for a lot of our chapters, at least specifically to Insulin for All, is that it's like a handful of people that are really following it and like doing all these meetings with the legislators and keeping the consistent communication and making sure that they hear these stories. We have a very live policy right now in New York State that's modeled off of CalRx. It's in the budget process this week, and so it's passed the Senate. Now it's like we're just hoping that it gets put into the budget. But that work in that chapter in New York is, we have about 10 folks who are really dedicated and are amazing partners. And I think that's another thing. If you plug into a network like UAEM or for us with TUN International, that already have some of these relationships and have the skills training to get your advocacy going, then you're connected to this network of all these people that already have all the expertise. Or not all of the expertise, but like you can find the different people who can support. So that's something that I always value because it can feel intimidating to get involved sometimes. Like I myself do not come from a policy background. I literally got involved in this work 6 years ago because I was so enraged. And I'm a painter, and did fundraising at museums for 10 years. Like this is not where I thought I would be at all. But the person that I love the most in the world, along with my kids, depends on this medication to live, and I can't even handle like the system that we have. So it can come from a lot of places, and I think just to say like one person can make a huge difference in that. When you have the relationships and the network, like I don't need to be the expert in all of these things. I'm absolutely not the smartest person in the room on so many issues. But when you have the whole collective and you have people that you can tap into, as you're doing at this conference this week, then it makes a huge difference to be able to make change. So.
Yeah, I would say I totally agree with Allison. I think being here in the room is a huge first step. It's a really active news cycle right now. And for better or worse, health is something that people care about no matter what's going on in the news. And so the fact that you're continuing to speak about it, I think is incredibly important and powerful. One thing that I will say that I've kind of learned in this process is that you can't be afraid to appeal to people that also may be caring about the issue for different reasons than you are. I know in my health system, and Chris spoke to this a little bit, but the cost to the system is what a lot of the people that I work for care about. And that is both good and bad. The cost of the system is incredibly important. I am more focused on the effects on the patient. But if I know that my healthcare system is really worried about how expensive the insulin is to their system in order to keep running, then I can advocate for a less expensive insulin to be integrated on formulary and to incorporate CalRx's insulin. Same thing goes for all the other medications that we struggle to have access to. As you can be aware, GLP-1s, we've almost lost complete access to in our healthcare system. It's been incredibly hard to keep some of these newer, incredibly effective medications on formulary. And if you can find ways to appeal to the people above you that maybe care about it for other reasons, keeping the lights on, making sure that the county health system continues to run, and getting your efforts in that way, that's also an effective way to make change. And maybe you disagree on the reasoning why, but it still causes the same outcome. So.
It's hard to follow. I feel like you're all covering so much. And I think Chris said it so well that programs like CalRx wouldn't exist at all if it wasn't for advocates like you all in this room. And we really just can't let our foot off the gas in this moment with all the federal attention now and all the great work happening at state levels, keeping that momentum going to sustain this work. Especially for CalRx. Right now, we're just funded through one-time sources, drug by drug. We don't have an ongoing budget at this point to take on more target drugs. So we really need the people power in this room to keep it going.
Thank you for that. I'll be quick. I know we're at time. I'll put my Marshall Gantz organizing hat on for this one. But what can an individual do? I think I created a career out of being so upset around the reality of my diagnosis of type 1 diabetes. I was like, why is this happening to me? And then eventually when I got older, why is this happening to so many others in such unjustified ways? Me going down the rabbit hole of trying to understand, like, why is this happening? Why is this happening? Helped me realize how pharmaceutical systems work, how healthcare systems work, why political organizing is important, why theories of change need to be wrestled with in a way that makes your organizing effective in a way that actually can create a new system. So I say all this to say, all of you have a reason why you're here in the room today. You need to explore that reason, dig deep into that reason, connect with that reason every day, and use that reason to motivate you to try to figure out, why is the world designed in the way that it is, and how can we create a better world together?
Awesome. Those are fantastic answers. Quick time check. Do we have time for? Yeah, awesome. I'm going to turn to the audience. Does anyone have a question that they would like to ask? And I'll just run the mic to you. All right.
Thank you guys so much. It's been great to hear from all of you. And so it's kind of been a theme where really understanding diabetes came through your own experience or the experience of a loved one. And I wanted to ask, for if you don't have like a personal connection to something you're advocating for, how do you come to understand those smaller details and make more effective advocacy if you don't have that really personal experience on those smaller details?
I mean, I'll just start. Your advocacy should be centered in the lived experiences most closest to the challenge. Allies, advocates, comrades are the best. That's the reason we can make change, is because people care for others, even if they don't have that exact experience. But those closest to the hurt also have the best answers for how to get better. So just check in with those that you're advocating for, and ground your advocacy in their experience.
Yeah, and I would add to that, I'm the person on this panel with no direct experience with diabetes. And as Chris is highlighting, that was why forming a patient advisory council was so critical. So the patient voice is really driving our work.
Yeah, I feel like right now, with everything going on, a lot of people have lost a lot of autonomy in general. And picking a topic where you feel like you can make such an incredible difference affects so many people is an easy thing to get behind. And really just trying to focus on how you've been feeling about everything that's going on and that real loss of autonomy, and really putting your voice behind it is so important. I also, not to be depressing, but I also, I didn't expect to have this diagnosis. I went through the majority of my life as a healthy person with no medical issue, and it came on suddenly, and I became a huge advocate, but I honestly am embarrassed to say that I felt like I hadn't really done enough before that. And the fact that it really forced me into the issue, I think was good, but at the same time, I was not planning to be diagnosed with this. And I think to be aware of the fact that even if it's not affecting you now, it's going to affect someone in your life at some point. Maybe not directly, but this is such a widespread issue that you're going to know someone either with diabetes or with any of the complex medical conditions that require these expensive, hard to obtain medications. It's just so ubiquitous, I would say.
I think we've pretty much covered it, but I would say, yeah, I think just one of the primary functions that Team International kind of serves is being able to ensure that the patient voices are the ones that are being counted in the experience, that are at the table, that from when these policies are being decided. Because as Chris said, when you have that lived experience, you're going to have the knowledge of what solutions are going to be the most impactful on the ground. And so that is hugely helpful. And you all have, the expertise in your lived experience in whatever field. Like if you're going to be going into medicine, then you have the experience you're having at the hospital. And so that is super helpful to understand that perspective in relation to advocating for these things. Our network is so wide of people, researchers, doctors, pharmacists, of all the people in the system that have this awareness. And so if there's a unification around like this needs to change, then it doesn't mean that you have to have, you don't have to hold that knowledge yourself with that specific disease area. You find the groups that do, and then we work together in collaboration to make the change together. So like right now, we've been so lucky to work with a doctor right here at UCLA who's doing like cost modeling for the New York legislation to look at what the savings might be, and just being to pull all those folks in. Yeah.
Excellent. I think we can take one more question to wrap up. Yeah, I'll come your way.
You mentioned that stable housing kind of plays like a big role in getting access to consistent insulin. What does it look like for like an unhoused person who has type 1 diabetes trying to access their medication on a regular basis? Is that even something that like is possible, or is there work being done there? What does that kind of look
Yeah. So one thing that I can mention is that refrigeration is a huge issue when it comes to insulin. I've seen a lot of doctors prescribe insulin to patients who have housing instability, not recognizing the fact that that person may have nowhere to store their insulin. And so that's a huge complication of the issue. Whether or not you're insured is obviously a huge problem as well. And a lot of my patients are currently losing access to their insurance because of the changes with Medi-Cal that have happened since January. But that housing instability really plays a role in just making sure that you have stable access to the medication. As Chris mentioned, I need my insulin every hour on the hour, but no matter what. And if you already are looking for places to have yourself be in a stable place, you can imagine how much more difficult it is when you have a very unstable refrigeration necessary medication to bring along with you. So.
Yeah, I echo everything Kate said. I think in terms of like solutions for how can you get insulin regularly to people that are unhoused or have unstable housing, um, I I did a practicum in my master's while I was at BU in South Africa, actually in Cape Town, and they have something called a chronic disease dispensing unit, which is kind of like it's a partnership with the government, which has a national health insurance plan, so the medicine is free. Partnered with kind of like the UPS equivalent in South Africa, which was a private distribution chain, somewhat almost like an Amazon, I guess you could say. And you were enrolled in the chronic disease dispensing unit after you get diagnosed by a doctor and then given an active prescription, where the state figures out like where you are. And this is in South Africa, where there's regions that are very kind of rural and underdeveloped, and even in those low resource areas, there would be like a community center or a church or just like a community center of some kind where they are an authorized distributor for people as a part of the CDU, the chronic disease dispensing unit. And you would have like a window of time where you were supposed to go to that unit to pick up your medication on a regular basis. And what we've been having conversations on the Patient Advisory Council is like, can we learn from models like that and try to implement here in California? So we don't have to recreate the wheel, but how can we think creatively around, and this isn't just like Chris thinking, right? Like the reason why the Patient Advisory Council is so great is because we have representatives from rural parts of the state as well that are closest to the issue of insulin deserts and insulin insecurity and unhoused folks. And so, tapping into the knowledge there and the expertise there, but then working with the state creatively to learn around what has worked in other settings is how you can create a system that works specifically to the needs here in California.
All right, and if I could get a round of applause to thank our fantastic panel. All right, thank you.